I'm going to be now talking about, the focus of the rest of the talk is going to be about work that I've been involved in with colleagues from Brown and Bradley Hospital. This is a team, Tony Spirito and Jen Wolfe. And I would just say on a personal note, Tony Spirito is someone I always really admired academically, so it's been a really wonderful experience to get to work with him. And Jen Wolfe is someone that I became close with in one of the professional societies that I participate in. So just to give a little, it's one of these lucky experiences. This project is funded by NIMH and is entitled Towards a Reliable and Valid Assessment of Preteen Suicidal Thoughts and Behaviors. This project is focused on improving how we assess suicidal thoughts and behaviors in this age group, and we'll be focusing on the ages of 8 to 12. We're nearly 3 years into this 5-year project, and so I have some of the results we can share from the first stages of the project, and then kind of preliminary findings from the current portion. So this project really grew out of a targeted call for research from NIMH addressing rising concern about suicide in younger children. In 2021, NIMH had identified child suicide as an emerging public health problem and convened this national roundtable series entitled Risk, Resilience, and Trajectories in Preteen Suicide. And this is really to identify priorities for prevention and research. Central themes that came from these discussions was this need for more reliable, valid, and developmentally sensitive ways to assess suicidal thoughts and behaviors in children. And there were these 3 key questions that were identified. So, do all preteens understand the concept of death? And how does a preteen's understanding of death affect their suicidal thoughts and behavior? Do preteens accurately report suicidal ideation on self-report measures? Do researchers ask questions about suicidal thoughts and behaviors in a comparable fashion? From this roundtable series, there was a notice of special interest released, and the development of the project that I'll be talking about today came from this. So why focus on preteens? There are kind of 3 major areas. I'll be talking about the rising concern, this understudied population for suicide, but with seemingly unique developmental considerations, and need for tailored assessment practices. But to start, I want to kind of focus a little bit on this developmental period. So what's happening in this middle childhood, 8 to 12 years old? Youth remain largely concrete thinkers, but are beginning to develop emerging abstract reasoning. This period is marked by increased social comparison, heightened sensitivity to peer acceptance, growing autonomy from caregivers, and early pubertal changes. Emotionally, children demonstrate greater self-awareness, but also an increased vulnerability to self-criticism. Over the last 15 years, the developmental context for children in this age group has really changed in notable and well-documented ways. And this is largely due to technology. So earlier and deeper immersion in digital media and social platforms. And we know that more screen time is linked with altered sleep, attention, and emotional patterns. I included a picture of my 2 children here that throughout the course of the study happened to fall in this age group. This was last summer, ages 9 and 11. And I think kind of highlights some of the dialectics kind of this time period, right? Holding stuffed animals from their favorite animated series and wearing, the shorts and the shirt that everyone has to have, or the types of shoes, right? So these the both ends of this time period. Okay, so let's talk a little bit about the rising concern. There's really, in the United States, been this troubling increase in suicide among this younger age group. And between 2010 and 2019, suicide deaths increased by approximately 135% in youth ages 5 to 12. Death by suicide represents part of the picture, Recent meta-analysis shows that suicidal thoughts and self-harm behaviors are already present in a meaningful proportion of children under the age of 13. So we can see here about 7.5% experiencing suicidal ideation, and smaller percentages reporting suicide plans, attempts, and self-harm. Clinically, we see this reflected in rising emergency department visits in this age group, and there are important long-term implications. Children who attempt suicide are up to 6 times more likely to attempt again during adolescence. And as you can see, even the patient I presented, that was the case for her, right? Initial attempt at age 12 and then has had another since. So thinking about this, hasn't been a ton of research, although I would say there's a growing amount of research on suicidal thoughts and behaviors in this age group. And studies have really tried to focus on unique developmental factors or distinct patterns. So there's some evidence to suggest that irritability and difficulty regulating negative emotions may be particularly salient risk factors for younger children. During periods of emotional crisis, preteens may be more prone to emotional and behavioral dysregulation, which can really increase this vulnerability to impulsive suicidal behavior. There's also indications that ADHD can play an important role. In one study of children between the ages of 5 and 11 who died by suicide, ADHD was identified nearly twice as often as depression. And suicidal behaviors in preteens, they're so far showing less premeditation, which is more often observed in adolescents and older age groups. There's also thinking about kind of the difference in social stressors. Children who died by suicide were more likely to have relationship problems with family members and friends, and less likely to have a boyfriend or girlfriend problems, right? So thinking about the uniqueness of this time period in comparison to adolescence, and really the need for this more developmentally informed approaches. There's also this question about existing assessment tools and whether we're capturing risk effectively in preteens. There was a systematic review and meta-analysis suggesting they may not be. The review found that tools commonly used with younger children perform poorly in this age group. One example, the Suicidal Ideation Questionnaire, which is a commonly used self-report measure, includes a question asking about whether you've thought about writing a will. Right, and so it's less likely that a suicidal preteen would have considered writing a will. Write a will is not, a term that's something that we would think about as often in this developmental period, then resulting in a lower total score on the SIQ, possibly missing an at-risk child. So in response to these gaps, this project was designed around 3 primary aims. So first is to identify best practices for assessing suicide risk in preteens. The second is to develop a comprehensive risk assessment battery. And then the third is to validate this battery in a sample of diverse high-risk youth. To accomplish this goal, the study had multiple method utilized. So it includes qualitative interviews with clinicians, youth, and caregivers, an expert panel to guide the assessment framework, and then empirical testing of the assessment battery. The sample is youth ages 8 to 12, admitted either to inpatient or day hospital, and so we recruit here on Bloomberg 12, and then also at Bradley Hospital in Rhode Island. And it includes both the child as well as their caregiver. To highlight, the admission can be for any reason. It's not exclusive to those who have had suicidal thoughts and behavior, and so there'll be an opportunity for some comparisons. So the first step of the project involved qualitative interviews, as I said, with youth, caregivers, and clinical experts. The qualitative approach was selected to capture this nuance, more developmentally and contextually specific indicators of suicide risk. We used a rapid, double-quoted qualitative analysis approach. Interviews were systematically coded, summarized, and synthesized into iterative, consensus-based process to identify key themes. And these have recently been published in evidence-based practices in child and adolescent mental health. So who were the sample for these qualitative interviews? We wanted perspectives both from experts and from families. So we interviewed 31 experts, including clinicians and researchers from child psychiatry, psychology, and social work, to really capture a broad range of professionals' perspective on suicide risk in this age group. We also interviewed 22 youth and caregivers. So youth participants were ages 9 to 16 who had experienced the onset of suicidal thoughts or behaviors before the age of 12, and caregivers who had had a child psychiatrically hospitalized for suicidal behaviors prior to age 12. And this really allowed us to try to get the lived experience of families navigating suicide risk in this age group. For these qualitative interviews, they were semi-structured. You can see the domains covered here, what we asked the clinician or research experts, as well as the youth and caregivers. So you can see we asked about warning signs, risk factors, on the expert side, procedures for assessing suicidality, any developmental modifications, which informants are used, the children's understanding of death and suicide, factors related to race, ethnicity, and culture. And then for the youth and caregiver, we asked about plans, preparation, intent, the youth's understanding of death or suicide, factors related to race, ethnicity, and culture, and how professionals and other people can help a youth who has suicidal thoughts and behavior. So there's quite a bit of content here, and I'm going to do my best to kind of whittle it down to kind of the key points. But from these qualitative interviews, and these were the key themes that emerged from the clinician and research experts. And so the first off was the importance of rapport building, really essential for helping children and caregivers feel heard, respected, and safe. There was a preference for semi-structured clinical interviews. Pretty much everyone agreed that screening tools can be a starting point, but really that interactive interviews are critical. There was a focus on needing developmentally appropriate methods, so incorporating observation as well as nonverbal activities like drawing, checking for understanding throughout, and this was a big theme that came up, is that you really need to ensure that the child understands each question during the assessment, so to be consistently checking for that understanding. Using a multi-informant approach, so the importance of integrating perspectives both from the child as well as from caregivers, and trying to understand what discrepancies potentially need when they appear. Focusing on behavior and emotion, and making sure to not underestimate low lethality behaviors. There was this thought that impulsivity and aggression elevate risk even without planning, right? For example, running into traffic was one of the examples given, right? That can be impulsive but then have significant impact. Attending to cultural context, so exploring family beliefs about mental health and suicide through open dialogue. And then ensuring clinician training, so really needing ongoing training to strengthen competence. There was this thought that many people are uncomfortable about asking about suicidal thoughts and behavior in this age group, and needing more support for training in this area. So here are some of the example quotes from I'm sure this teeny tiny, but I'll read a couple out here. So with a child, it's easier for me to do an interview because as a clinician, you assess things such as their level of understanding. It gives you ability to double check responses. It's helpful for me to figure out what's going on when this happens. I guess when that thought happens, what do you do next? Or who helps you? Or what helps you? And then you can see down on the far right one, I think some clinicians won't ask a younger person because they're afraid. So reflecting this need for additional training. So here is the overview of the key themes that emerge from the youth and caregiver interviews. In terms of the understanding of death, youth did report understanding the permanence of death. Some caregivers were unsure, and this was often due to their limited conversations about death within families. There was a focus on understanding the contextual stressors, so including sadness, anxiety, isolation, bullying, family conflict, academic stressors that were commonly preceding suicidal thoughts and behaviors. There was this theme of hidden distress, so many youth concealed feelings due to fear of consequences or burdening others, and caregivers were often unaware until hospitalization had occurred. Youth expressed a wish for adults to ask more direct questions about mood and suicide. This planning versus impulsivity gap, there's a lot more to be said here, but many youth reported planning over days, and caregivers frequently perceived attempts as impulsive. So this discrepancy is important to highlight in terms of thinking about these warning signs, degree of risk, how do we use this information to support families' safety planning moving forward. Both caregiver and child interviews emphasize the importance of recognizing how identity-related factors, such as gender, sexuality, race, religion, and cultural background can impact one's beliefs and attitudes around mental health, treatment, and suicide. And preteens noted this desire for adults to check in with them, to ask how they're feeling, and to directly ask about suicide. So some of the child quotes. I didn't let anyone know because I thought it would be too much for other people to handle and that I would just be a burden to them, and I didn't want to do that. I wish my mom would have noticed how I felt or asked how I felt. I don't know how social media know how I feel in the brain, but every time I scroll, it's like all suicidal stuff, and I'm like, I can do that. I can take the pain away. And then some example quotes from the parents. I feel like everyone's culture is different, so I think that just being as individualized as possible is the best way to approach it. And just ask questions, not to assume. Ask the questions even if you don't know, or if you think you know and may not know. I think the best way is to just ask. She said she didn't want more stress on me because I have enough on my plate, and she didn't want to be more of a burden. He's aware of the permanence, but I think he's hopeful that he would come back somehow. Okay. So our integrated takeaways across these informant interviews from these qualitative interviews that were then used to inform an assessment tool that we've worked to create. So again, this relationship and rapport are foundational. Assessments need to be developmentally sensitive, interactive. Multi-informant perspectives are essential. And discrepancy can yield important clinical information. Behavioral and emotional indicators are key. There's an importance of assessing understanding of death directly rather than inferring comprehension based on age. Direct, explicit questioning about suicide is valued, and contextual stressors and identity factors shape risk and disclosure. Ongoing training is needed to support clinician competence. Okay, so that was step one of this project, right, the qualitative interview component. Step two is where there was an expert panel to provide feedback on commonly used self-report tools. And so you can see here there were 16 experts for this component of the project that rated 6 youth suicide tools. And the questions that we asked were about attention to developmental appropriateness, clarity, clinical utility for preteen populations. And a number, just to summarize, there's a lot more to go into depth here, but just to summarize some of the key points that came out. There were concerns that many of the existing measures are too abstract or cognitively complex, and concepts like intentionality and future thought might be hard for kids to understand or report on. There was an emphasis on the need to define terms like suicide, firearms, and will. Ambiguity in language. and this theme I think will come up more as I show some of our preliminary findings, but what a child may consider to be a suicide attempt might not fit a clinician's definition. And kids may struggle to label something as just true or just false. In terms of recommendation, they suggested using more simplified tools. Questions about timing should be specific, anchored to specific events, importance of keeping instruction brief, having more contextual items like emotions, situations, and triggers. Okay, so taken together, both those qualitative interviews and then the expert panel that were providing feedback on specific measures, we developed a semi-structured clinical interview for caregivers and youth, as well as a comprehensive battery of self-report and behavioral tasks. These behavioral tasks included cognitive assessment, implicit association task. Okay, so here are, gosh, a ton of content on the slide, but just to highlight some of the key themes here, right? These are the areas that are included in our baseline semi-structured interview for youth and caregivers. So we really intentionally gather information from both perspectives with, again, this goal of exploring discrepancies rather than treating them as errors. So some components to highlight, there's really an intentional rapport building section. We try to use concrete language. There's an opportunity for drawing. There are direct assessments of death understanding. So we ask explicitly about the child's belief and understanding of death and dying. The ASQ screener is included. This is a commonly used measure, including here at Hopkins as part of the interview. In terms of context factors, we look at both behavioral and emotional context. We ask questions about something that happened that made you want to end your life. What were you feeling before you did this? How long did you think about hurting yourself before you did something? Did anyone tell you about this, or was anyone there? We use direct language and try to be as clear and explicit as possible. We include questions about belonging, because this was somewhat emerged from that the qualitative portion. So, are things that about you that make you feel different from other kids? And we end with reasons for living. Here's an example of one of the drawing components of the interview. Again, we included drawing to really have this alternative way to express thoughts and feelings that could be difficult to articulate. Not the most upbeat image right here on the left, but a child you can see depicting, looks like taking some type of poison or medication, hanging, and then I think with the intention to draw stabbing self. And then we also ask them to write what they think when they're having thoughts about ending their life. And so some of the, I'm worthless, they would be better off if I wasn't alive, no one cares about me, I'm stupid, I should die. Here is the visual images that are included in their interviews to help identify and describe emotions during significant events, both getting at the kind of the pre-context as well as after. And then the self-report and behavioral task battery is across a number of different domains. So we look at mental health and behavior, social and emotional functioning, cognitive functioning, environment and context, family dynamics, developmental milestones, treatment history. And then on the right here, this shows a kind of one of the tools that we use to help children move through this study. So we're still actively recruiting participants. So these are really kind of preliminary observations that I'm going to share here as this kind of early snapshot. So this is the kind of characteristics of our preteen cohort thus far. 63 of these participants were recruited here at Hopkins. The sample is relatively balanced by sex and spans the ages of 8 to 12. There's the largest representation among 11 to 12-year-olds. In terms of race and ethnicity, the cohort is predominantly non-Hispanic, racially diverse. The majority of the participants do identify as white. You can see that from recruitment location, kind of a nearly even split between inpatient and partial hospital program. At discharge, ADHD and anxiety disorders were the most common diagnoses, followed by mood and stress-related disorders. And you can note there's the prevalence of autism spectrum disorder here, and this is kind of, I think, been maybe not a surprise, but an area that we are plan to investigate further. So this figure illustrates reports of self-injurious thoughts and behaviors, suicidal ideation, suicide attempts, which you can see were all commonly endorsed. 57 youth reported a suicide attempt, which is 37% of the sample. What you can see is this discrepancy, there's this discrepancy across informants, and so parents are reporting higher rates of non-suicidal self-injury and suicidal ideation overall, whereas children are reporting more suicide attempts than their caregivers identify. And there's going to be kind of a little bit more to share on that front. This looks at reports of passive and active suicidal ideation by age, and across both parent reports and child reports, we're seeing this clear developmental trend of increasing steadily over development from ages 8 to 12. And this pattern is both for active and passive, and kind of generally a little bit more consistent across informants, but with parents reporting slightly higher rates overall. And then this is suicide attempts by age. So similar developmental pattern. Reports of attempts increase steadily from ages 8 to 12. The sharpest rise occurring in between 11 and 12. And again, we're seeing the signal that our children are reporting more attempts than their caregivers. So this discrepancy really we need to investigate further, but I guess some initial thoughts from me might how attempts are being interpreted. There might be hidden or unobserved behaviors, over-recognition by caregivers, under-recognition by caregivers. Caregivers might be relying more on observable behaviors or medical events. Children might be reporting attempts based on their perceived intent, and I would say that, that's pretty consistent with what I've seen in some of the interviews. Okay, and just a few more kind of interim findings. I know we're getting mindful of the time, but most participants have correctly endorsed that death is irreversible, countering this assumption that young children lack capacity to understand the finality of death. Most of the participants know someone who's died and so have that kind of lived experience. About a third reporting knowing someone who had self-harm or attempted suicide. The mean age of first suicidal thoughts was under age 9. Some children reporting onset as early as age 3, highlighting this need for earlier screening and prevention efforts. Many children reported recurrent thoughts, intense negative emotions. There's a lower percent that report a plan with a time or place, which does seem consistent with some of the signals in prior work with less premeditation. Of those with a suicide attempt, the mean age for the first attempt was at age 9.5. Preteens reported a variety of methods, including, you can see here, hanging self, cutting self deeply, overdose, jumping from a high height. Over half of the participants reported feeling different from other kids, and again, getting at the social and identity-related stress. Family emerged as the most frequently endorsed reasons for staying alive, emphasizing the central role of the caregiver relationship in prevention and intervention. Okay, so what's to come? So our immediate goal, right, is the priority is completing recruitment and continuing the longitudinal follow-up to better understand the trajectories of thoughts and behaviors over time, I've been talking about the baseline assessment, but we do monthly questionnaires and then more comprehensive interviews at 6 months and 12 months with both the child and the parent. So we're conducting reliability and validity testing of the assessment battery, working to identify clinically meaningful subgroups within the sample. To me, this is something I've been really interested in doing this study. It seems like there are kind of these almost similarities, right? Some of the participants seem more like adolescents, right? And then there seems to be this unique, younger, tend to be younger, male, kind of more aggressive, impulsive group. And so understanding some of those differences. Important goal is to translate this work into practice through the development of clinician-focused training modules, really to support this developmentally informed suicide risk assessment in preteens. Okay, so for now, though, what am I hoping to emphasize? There's a lot to consume here, but if I were to give a take-home message, I think there's clear evidence that we need to start talking about suicide earlier, and kids and parents in the qualitative part of the study want us to, right? So these quotes like, if adults ask directly about experiencing self-harm or suicidal thoughts, then it shows they care. I just really think it's those frequent check-ins. I can't say it enough about that. I feel like even in the school system, if they knew how to check in. But also say, we weren't sure how recruitment would go for this study, but I would say it's gone incredibly well, and that parents are eager to contribute to knowledge in this area, which is me kind of further evidence that this is something that we need to be addressing in this age group. This is the current American Academy of Pediatric recommendations for suicide screening. So they recommend 12 plus universal screening. Youth ages 8 to 11 screen when clinically indicated. And then youth under the age of 12, screening's not indicated unless there's some type of warning signals present. Our policy here at Hopkins is to screen 10 plus when clinically indicated. And so I think we have some work to do, right, in thinking about how we might be able to make suicide screening as a more routine part of mental health and medical care. There's this really wonderful newly published research, this is from January 2026, that the title you can see here is Asking Pre-Adolescents About Suicide is Not Associated with Increased Suicidal Thoughts. It's a really well done study where they have a lower risk and a higher risk age group. And the findings really support that repeated suicide risk screening in pre-adolescents is safe and does not inadvertently increase suicide thinking. So just kind of more evidence that we should be asking. So I want to thank everyone who has participated. This includes the expert panel I mentioned as the study consultants. Our study team from Brown and Hopkins is shown below here. Megan McCann is in the audience, my research coordinator, who this would definitely not have been possible without her efforts, and Mackenzie Summeralder, who's done an amazing job helping us recruit from the day hospital. So, plenty of time for questions.
Thank you, Dr. Reynolds. What a valuable project and a really terrific presentation. I was really struck by that point that these kids want parents to ask directly about suicidality. I presume the corollary to that is they're not that likely to simply offer it up.
Yes,
that it needs to be asked directly about. Was that surprising that the kids wanted that?
Yeah, I think I was a little surprised, and I do think there's a duality here, is that they're clearly saying they're not offering up the information on their own, and they're not offering it up. They talk about this worry about being a burden, right, or it's too stressful for families. So I've thought a lot about this in terms, I'm looking at my day hospital child psychiatry team here in the front row, but we do a lot of parent work there, obviously on the inpatient unit too, but I've thought a lot about how do we coach families to help receive the information that children are giving, and how to create more of these check-in approaches to overcome some of the fears about reporting. And so you're so right on this duality of like, they're not going to offer it up, but they do want us to ask. And so how do we coach families to help with that?
You think part of the fear of offering it up is the worry that there'll be this immense amount of alarm and it'll be so destabilizing to everybody.
In some ways.
Right.
So I think there's both fear about being a burden to family. I do think there's a fear about kind of getting in trouble or hospitalization. And so how do we reassure that we can help create safety plans, help support you, and that when you're reporting, it doesn't mean kind of automatic do not pass go, right, entry to the emergency department or inpatient unit. And then we've got to find ways to help you, right, and help you cope. And that there can be relief, right, from these experiences.
Thanks. Other folks have questions? We have lots and lots of questions. Yeah, go ahead.
Yes, no, that's an excellent question, Mackenzie. Yes, so we do ask who it is that they know and the outcome, if it was a suicide, whether the person had a completed suicide or not. I would say, like, anecdotally, my experience is that there's a fair amount of knowing someone at school, knowing a family member, like a cousin is a common response, like some type of same-ish age family member. I think one of the surprises that a number of kids have reported that they knew their parents had had suicide attempts in the past, which has been interesting. But there is more information that we are able, it's part of the study and the entered information.
Interesting. Who else had their hands up? Dr. Giannopoulos.
So this is something that's new to me, right, is using this method, and it's been great to kind of learn the value of this. So one of the research team members at Brown has had this interest in understanding if there is any difference potentially in imagining versus having thoughts. And so we ask questions about, have you ever imagined what it would be like? Do you see images in your head? And if they answer yes, we say, would you be willing to draw what you imagine? And that's the prompt. And then there's a separate set of questions and prompts that ask more about the thoughts. And so you can see in those two bubbles I provided, the first prompt is, can you draw what you imagine? And then can you write what you think? There's some question about whether there are differences. I would say, some kids have troubles with this, and not every kid feels comfortable drawing or writing. It's not forced, right? But there's the opportunity to provide that. Yeah.
Thanks. Dr. Kronsberg.
In the pathway. Yeah. I realize am I supposed to be repeating the questions? I'm not following all the rules. So I was going to say, how am I going to?
Right. Does knowing someone who's made a suicide attempt make it more or less likely that?
Yeah. So I think we could ask that question of the data that we have. And I imagine it's going to be, I think doing this was just, not that I didn't think about this before, but it seems like there are a lot of different kind of uniqueness, right, of the experience. And so I can imagine in some cases knowing someone and maybe knowing someone that's gotten help or support, right, it's hopeful, right? It's like, oh, they've gotten help. Or I, had a kid talk about the parent, and they're like, but they were able to overcome it, right? They had talked openly about their own experience and how they engaged in treatment and, are living high quality of life. And so I think there's like the positive, the positive. I would say there's also, I definitely think there's a negative where they feel like they experience people having a punitive response to having these thoughts. And so I think as much as we can decrease that kind of the concern about that punitive response. Claire, I thought about the work that you're doing with Karen too, and the adaption middle schoolers, right? I'm wondering if there could be even like a downward extension, even, I'm not sure, it's 6th through 8th, 6th, so I was like, maybe we could get to 4th or 5th grade, but too, and also thinking about how do we help coach schools and others to help have a supportive response, right? Should these concerns present in the school setting?
Got time for one more, Dr. Bruce.
I have definitely made, so kind of repeating the question, are we asking clinically about content on social media and asking patients like that? I have definitely changed that practice for myself. It's like kind of one of the most common kind of questions that I'm asking about with patients now. It's also a little bit of an indicator on how they're feeling, I've found. So like in some of my longitude, outpatients, like what's your algorithm showing this week, and kind of, is it everyone celebrating the U.S. hockey wins, right? Or watching the salty Canadians get their stuffed animals with their medals? Or is it, like really sad content? Or, and so to me, I think this isn't a research answer, but kind of a clinical answer in terms of like, I do think it's important information. I think there's a bunch in the study that asks about what you use in terms of technology. I am impressed just how many of these kids in this age group have phones and have unfettered access to social media. I do think there's some, changing tides that we're seeing happening culturally there, but this group, many of them have had unfettered access to technology